I think we have some time left for questions. I hope you saved more or less the questions you wanted to pose to the speakers you have heard so far. We have an expert group of panelists as well. Please, if you have one question, raise your hand and I will give you the word. Okay, while you are thinking to what you want to ask, you have a question. I think you have a microphone. You can go ahead.
Thanks, Manuel. Just a point about the inter-stent rotablation, whether you change your policy regarding when you are rotablating inside a stent. Because in the case you showed before, I would personally start with a bigger bear at higher speed. And this is the only, to my opinion, this is the only indication that I would start with a bigger bear at higher speed. Otherwise, the 1.25 in a big vessel like that, it won't do anything. And sometimes when you want to crack a stent, it's not absolutely necessary to go through. Just touch the first part of the under-deployed stent, and then you modify. And then you can go with a non-compliant balloon. No, what's your opinion on that? We're going to present the case tomorrow and show this.
Well, I'm only valuing your experience because, as Flavio said, I don't have so much experience in that because I tried to use rotablation before implanting a stent. This was one of the very few cases I happened to do. And I take your comment as a good suggestion. So next time I will change my policy and I will take a bigger bar if needed. But so far, this was perhaps the second case I did myself. Mm-hmm. But perhaps Bella has a comment on this.
We recently published a paper actually in Euro-intervention. And of course, not all of the cases with stent rotablation was our patient, because we got the patient from many other institution because they had the problem and they have seen the not well positioned stent, and after they ask for help because not the restenosis is the bigger issue. The issue is the potential risk for stent thrombosis. So of course in case of stent rotablation we need a higher burr. We know that the optimal burr vessel ratio is an interesting question, and I have seen your results from the Rota register, and it was 0.45, which is a little bit less than I expected, because the optimal is 0.5, max 0.6. But that means we are on the safe side just before, just to avoid potential surgically manageable complications. So probably that's the most reason for choosing the smaller burr for all of everyday practice. So of course higher burr for stent rotablation and lower burr vessel ratio for the conventional rotablation procedure.
Thank you. Miroslav?
Yeah. Thank you for your comments. I personally believe if we do a good job in the cath lab and prepare lesion correctly, then we can of course avoid such situations. But however, we still see even in high volume centers 1 a month such situation that we cannot crack the struts using even OPN balloon, so we have to rotablate. So I personally, this is my personal experience, I rotablated in 12 patients with in-stent restenosis or not in expanded stents, and all cases which I personally performed were successful. In one case, I removed the old stent, just pull it out without perforation. I was lucky, and put it one stent, a new stent, and could manage this case. But however, this also my experience to use bigger diameter of the burr, higher speed, and this procedure should be definitely performed only in high volume centers with a lot of expertise.
Miroslav, let me challenge a bit what Bella said in the beginning. We don't necessarily need surgical surgeons on site to do rotational atherectomy. Would you also support this statement, and I give the word to Bella, also to do this kind of cases? Would you be quiet to do these kind of cases without having a surgeon backing you up?
I think high volume centers have already surgery behind. Definitely to rotablating stent, I would suggest to send the patient to the center with cardiac surgery.
Yeah, that's a very important point. Let me ask, how would they do in Spain? I see Beatriz here. Too much quiet.
Yeah, I think I don't have a really good experience in this kind of stent under expansion. And I think that the rota has some limits or boundaries. And I think maybe in these cases, maybe laser could be better and safer. But I disagree, but I think is another controversy that I think is safe to do these cases in centers with good experience without cardiac surgery. Because I think this complication, the acute perforation, you need to solve in the cath lab. There is no time to go to the surgery room. And I think in my experience in a center with cardiac surgery, the surgery didn't solve these cases. Thank you.
Could you imagine?
How about bar entrapment there? How would you manage this without the surgeon on site, in case the bar would entrap?
I think there are some tips and tricks. I happened to me once. So I tried to pass another wire, a balloon, try to inflate, try a second guiding catheter. I think each case is different, but I think you can solve this in the cath lab.
So I definitely like to comment again. So in this patient subset, rotablation in stent, I think this is definitely recommendation to go to the center with a high expertise level. This is, I think, very important topic.
Thank you.
I have a different question to panelists. Could you describe an IVUS observation to establish indication to rotablation? Because it was not mentioned.
Who wants to take the question? Can we give the microphone to Dr. to Bella?
Yeah, the problem is with IVUS, that in many cases in which rotablation is very useful, you cannot cross the lesion with IVUS. So it's difficult to estimate, and that's the most challenging cases. Of course, if you plan to do a bifurcation lesion and you think about a proactive use of rotablation in which the lesion is not extremely tight, in that case, of course, IVUS could help to optimize your strategy. But I very rarely use IVUS for establishing the need for rotablation in my institution.
Thank you. We have a very last comment from Dr. Gohl.
I have two comments. One for Flavio and the situation of a stuck burr. What I observed sometimes in cath labs is that the movement of the burr is very, very rapid, like that, and this is completely against the meaning and the purpose of sending a lesion. That means that the correct advancement of the burr should be a slow one. You really should send the lesion, and you should not be the first over the lesion. What I have the impression sometimes interventionists think they should gain. They should come as fast as possible over the lesion, and then there comes another physical situation that the burr gets a speed momentum, and by this speed momentum, the burr is able to be more or less slashed over the lesion, and then it is trapped beyond the lesion, and you cannot take it back. So when you send the lesion very carefully, you can avoid in many situations this stacking of the burr. And the other question is for you. There is no thinking now in the development of the rotablator to get rid of the gas. I understood.
So let me first ask: do you want to reply, Flavio, or do you? Because it was, I'm not sure it was a question, but.
No, indeed. One of the nice things of rotablation is that there is absolutely no science on the way you use it. We all learn from our experience. I like this picking technique. I have never had a bar entrapment doing like this. And I have seen several bar entrapment maybe because of too push, not gentle as you recommend, but some people keep on pushing and then the birds get entrapped. So it's it's kind of handcraft work. So it's there are no rules for this. It's about experience, and this is what it makes difficult and what makes people being afraid, because until you get such experience, you have complications and it takes a long time. So I think these kind of meetings are very important to share. It doesn't mean that the way he does or I do is the good one. You will learn your own way, and someone will pay for the price of it.
Thank you.
Yes, the question that was asked was in terms of whether we continue to have support for the gas-driven system. And in the labs right now, we are investigating alternative power sources, the way we would term that, both in terms of ways in which the gas could be delivered in easy ways to the system, staying with the gas system, as well as non-gas electrically driven system. What I would like to add, though, is from our perspective, this technology, the reason why it works is because it is very safe, and the mechanism of action and how the torque is transmitted by the burr to the lesion is most important for patient care. Any change that we make to the technology, that is the assessment that we are doing to make sure that we don't end up affecting that in a negative way. So stay tuned. I would say that in the next year and a half, we would be able to share with you more specifics on what we plan to do.
Thank you very much. We waited 25 years, so we can wait still a couple of years.
Yeah, thank you for your great presentation and introduction of the system. I don't know, don't remember exactly who of you was for animal testing in Paris. Maybe only me. So I could test in Paris in September last year. Could test this or use in my hands this new system in animal and pick PCI in a small pig, and it's fantastic. It's definitely a more user-friendly system, easygoing. So I'm quite sure if we teach younger doctors correctly from first step, so they can be very happy with this new system, and I think we can go more brighter to prepare lesion using a rotablator and not as only bailout situation.
Thank you very much. I think we are now ready for the last talk of this session. Actually, Didier Carrier has a very important responsibility because you are between us and the coffee break. So he will present us with this most interesting case.